All, thank you, Avis, for the opportunity. So today I'll be presenting on congenital X-linked retinoschisis, its demographic profile, clinical features, its natural course, and surgical indications. We have analyzed 70 eyes. So the prevalence report has been between 1:5,000 to 20,000, and you can see this is one of our patient which came with foveoschisis, and OCT obviously shows the spoke wheel pattern and everything. Even the fundus shows this meso phenomenon, which is nothing but the accumulation of potassium and vitreous bales. So mutation in the RS1 gene, which codes for the retinoschisin, a protein that helps in cellular adhesion as well as cell-to-cell interactions, and females are rarely affected because it's X-linked, so males will be affected, and it's in first decade of life. So this was a retrospective study, 7 years data. We included 70 eyes of 35 patients, a data set including demographic characteristics, phenotype, frequency of follow-up or surgery, surgical techniques, details, pre and post-operative visual acuity, and complications of congenital X-linked retinoschisis patients were obtained and analyzed. So this is in summary of our results. I cannot put every tables, but the total number of patients were 35 and 70 eyes were included. Mean follow-up time in months were 35 months, and most common phenotype was type 3 retinoschisis according to Preiner et al. Classification, which is complex type. It was in 77%. We have done OCT also, and mean central foveal thickness in microns was 531 microns. Number of eyes underwent laser photocoagulation was in 2 eyes, and the number of eyes that underwent vitreoretinal surgery was 5 eyes. Mean age at initial presentation was 6.9 years, and median baseline visual acuity of patients undergoing vitreoretinal surgery was 1.8 logMAR. And most common cause for vitreoretinal surgery in our series was rhegmatogenous retinal detachment, which was seen in 80% of the cases. And one eye had macula threatening schisis, so that also we have operated. Most frequent vitreoretinal procedure was pars plana vitrectomy. We have done all the eyes vitrectomy only. No buccal was made owing to posterior breaks and grade 2 PVR. Anatomical success, 90% of the patients had anatomical success, with median final visual acuity was 0.6, and mean follow-up time in months was 26 months. So in discussion, most common phenotype in our study was type 3, that is complex, followed by type 4, which is foveo-peripheral. Rhegmatogenous retinal detachment is the most common cause of surgery in patients with X-linked retinoschisis, and in our series also it was the similar case. And RRD in XLRS is seen in 10 to 22% of the cases with retinoschisis. Even Rosenfield et al. Reported rhegmatogenous RD to be the cause for surgery in 75% in the series of eyes undergoing surgery. Our study, RRD was the case. Of course, the total RD was in 4 eyes, and 1 eye had macula threatening schisis, and intraschitic hemorrhages was present in 5% of the cases. And as I have mentioned, vitrectomy was the choice of surgery in all the cases owing to posterior breaks and PVR changes. Even Rosenfield and Regelo et al. Found PVR as the most common pathology complicating the outcome of the surgery, and they require multiple frequent surgeries, 2 or 3 surgeries. PVR, I've already mentioned that 1 eye had PVR grade 2 changes, but no patient required repeat surgery except silicone oil removal. We have used 5,000 centistrokes oil. Rosenfield et al. Reported success rate of 87% after an average of 1.2 surgeries per eye, with visual improvement in about 50% of the eyes. And we had anatomical success rate which was 90%, which is anatomically. So it was a retrospective study with a wide spectrum of presenting features. We did not encounter any atypical features like macular ectopia or dragging or anything. Here the family history and screening is very important. Genetic analysis we could not do because of lack of affordability. And rhegmatogenous RD is a vision threatening complication of X-linked retinoschisis we have to keep in mind, and surgical intervention in the form of pars plana vitrectomy or scleral buccal can be performed. Many authors perform buccal first, and if buccal fails, then they will undergo pars plana vitrectomy, but we have done all the cases pars plana vitrectomy only. Multimodal imaging like OCT can be an assistive tool to find out the amount of schisis, because some patients may spontaneously regress. And ERG can give varied findings. In our case, out of 70 eyes, 62 eyes had electronegative B wave, where the 8 eyes had normal A and B waves with lower amplitude in both the scotopic and photopic conditions. Thank you.
Thank you, Dr. Das. So, the next one is Dr. Jyoti. Are you ready? Okay.
Good afternoon, everyone. Thank you, AS, for providing me this opportunity. So, I'm Dr. Meewal Jones. I am presenting on the topic long-term visual outcomes after femto laser-assisted cataract surgery. So, about FLACS. FLACS is an advanced technology in cataract surgery. It is a computer-guided laser linked to an optical imaging system. So, less studies are only available regarding the long-term refractive outcomes after FLACS. So, purpose of my study is to evaluate the long-term visual outcomes in patients undergoing FLACS. So, it is a retrospective study. So, we took the records of 100 eyes of 68 patients underwent FLACS in Bejan Singh Eye Hospital, Nagarkoil, who are having at least 1 year of follow-up from January 2016 to July 2021. We excluded the patients with retinal pathologies, glaucoma, and any corneal pathologies. So, the procedure was done using Lenses femtosecond laser system. So, 4.8 mm diameter of capsulotomy, 5 mm diameter lensectomy, and corneal primary incision paracentesis were made. And if patient is having already pre-existing astigmatism, we had given arcuate incisions. Grid or chop pattern was used for hard cataracts. Then chop or cylinder pattern was given for soft cataract, and then patient was shifted to OT for doing phacoemulsification with lens implantation. So these are the data collected. So pre-op and post-op visual acuity, then cylinder power, IOP, and complications were noted. Then intra-op we measure use of any astigmatic relaxing incision used, type of intraocular lens place, and complications were noted. These are the results. So, mean age of the study population was 63 years. Of this, majority were from 61 to 70 years. So, majority were, our study population were females, that is 56%. Mean follow-up period was 25 months. Then these are the average values of the parameters obtained. Then after this 68 patients, 12 patients were having mature cataract. Then arcuate incision were done for 36 eyes. Then immediate sequential bilateral cataract surgery was done in 15 patients. The pre-op best corrected visual acuity of 0.4 improved significantly to 0.092 at first follow-up and to 0.91 at final follow-up. There was no significant difference in best corrected visual acuity between first and final follow-up. Then we also found out that uncorrected visual acuity, cylindral values, and intraocular pressure, the pre-op and final follow-up results were found to be statistically significant. Then no complications were noted. So, about discussion. Then similar studies such as Satana et al. Done similar study, and they found out that the visual outcomes were better in FLACS compared to conventional phacoemulsification. FLACS have a significantly less intraoperative complications. Our study also found out that the excellent visual outcomes achieved immediately following FLACS, and there were no intraoperative complications. And our similar findings were get from another on study also, A et al. They also found out that the visual outcomes were significantly improved after FLACS. Then Mohammed et al. Also found out that preoperative uncorrected and best corrected acuity were improved, and this effect was quite stable during the follow-up period of 12 months. Then in our study, we found out that the visual outcomes achieved following FLACS are sustained during the long-term follow-up. So conclusion, excellent visual outcomes achieved immediately following the FLACS were sustained during the long-term follow-up also. Thank you.
You have mentioned no intraoperative complications in any of the case. I mean, quite rare it is.
I'm actually no visually threatening intraoperative complication like that.
Yeah, but you should, because usually it is very rare that you don't have any complication in any of the cases. So you have mentioned no complications at all.
No,
So that's a rarity.
actually, visually threatening where we were,
Or manageable complications.
yeah, manageable complication,
Yeah.
not severe
But that
complication.
should be mentioned.
Yeah, okay, ma'am.
Okay, are the surgeries are done for the same surgeon?
Yeah, yes, ma'am.
Same surgeon.
Same surgeon. Thank you.
Good afternoon, ladies and gentlemen. I'll be giving a case series on posterior polar cataract, a surgical black hole. A short introduction. Generally, you know, posterior polar is present at birth. Now, there may be two types, dominantly inherited and sporadic. Dominantly generally have a variable expressivity. However, you'll find a lot of times they are bilateral, and sporadic may manifest at a later age, but the ones which are unilateral are generally sporadic. There's a positive family history in around 40-45% patients, and it is bilateral in almost 65 to 80% studies. Various studies have reported this, and there is a mutation on the PITX3 chromosome 10. Now, this is generally on the posterior pole of the lens associated with remnants of the tunica vasculosa. What is important here when you treat these patients or manage these patients, you need to know that this is generally tightly adherent to the posterior capsule, and it is often associated with a pre-existing dehiscence. And studies have reported various rates of dehiscence ranging from as low as 7.1% to almost as high as 36%. There are various studies available. There's a classification also giving. What you need to remember is type 3 and type 4 are the ones which are most prone to pre-existing dehiscence. That is where you expect complications. Type 3 are the 3 and 4 are the ones where you need to be careful when you operate them. Now, this was a analytical study of posterior polar cataract. This was in a zonal center of the armed forces where I was posted. 46 eyes of 38 patients with posterior polar cataract underwent phacoemulsification with a PCL implantation. All were operated by a single surgeon and on a Bausch & Lomb Stellaris phaco machine. And the surgical factors of interest in our study were the rate of PCR, the nucleus drop, and post-operatively the best corrected visual acuity. Another important thing what people need to remember is you have to counsel these patients, because patients with a type 3 or type 4 and a larger polar, which is especially dominant, they might have amblyopia pre-existing because it has been present since birth, and a lot of times this amblyopia is not reported because it is in the range of 612 to 618. Binocular vision is very good, so you have to counsel these patients. They might not have a full correction of visual acuity 612 or 69 post-operatively. We excluded all cases with higher than grade 3 nucleus, and the parameters during surgery were generally low flow. We reduced the bottle height, we reduced the vacuum, and power varied from 20 to 30 because the highest grade of nucleus that we had was grade 2. So a lot of times, and the grade 1 nucleus could be removed during the just the epi mode itself. Now, the general principles that we followed were we kept a smaller CCC of around 5 mm. Denser cataracts, grade 2 plus, we kept a larger CCC. No dissection was done. This is standard for polar cataracts. Tried to get a golden ring in all cases because that is a marker of a good delineation. That is where your nucleus removal becomes easy. If you don't have a golden ring, and then you go ahead with the phacoemulsification, there are chances you will destabilize the entire epinucleus and you will end up with a dehiscence, especially if it is tightly adherent. What you need to remember is do not rotate the nucleus. Generally, a grade 2 nucleus you can manage without rotating also, and you can phacoemulsify it in the bag. A soft cataract during hydrodelineation, try and prolapse it. One edge of the nucleus prolapses, removal becomes very easy. You don't need to emulsify in the AC, but partial prolapse makes your life easier. Grade 2 nuclei were present. Slow controlled chopping in the bag without any rotation was done. Another important thing that you need to remember during the surgery is a picture similar to this. You can see this image here. This is what is a pseudo hole. Now, this looks like a rent, but this is actually not a rent. So don't be alarmed if you see this. This is a pseudo hole. This can give an appearance. This is the plaque which is removed during the phacoemulsification, and you have a remnant. So this is not a rent, this is a pseudo hole. Now this, I would say, is a class type 2 polar. We go ahead with the surgery. You see there's hardly any nuclear sclerosis. It's a pure polar cataract, a small CCC. Do a gentle delineation and in the back phacoemulsification, and then you remove the cortical matter wedge-wise. One step which I have not shown here is what is very important when you're removing the phaco probe. After doing the phacoemulsification, in your left hand, take the visco cannula and through the side port, inject visco into the AC so that the chamber does not shallow at any time. This is what you need to remember. If there are no fluctuations in the AC, chances of a dehiscence go down. Another case, this is a larger cataract, polar. I think it's a type 3, I would say, a delineation gun. Everything goes on fine here. If you see, the phacoemulsification is done in the bag, and we remove wedges of the epinucleus and then do the IA. Now, everything is fine till now. Now you can see it is adherent to the capsule. You can make out not a single piece of the polar has come out as yet. When we come to the last stage, suddenly you find there is a rent in the capsule. Now this is the last part which has come up. So do not disturb it, and you can easily implant a IOL in the bag. So you have to be aware that this situation might arise in any case of polar cataract. So we had a total of 46 eyes of 38 patients, 20 were male, 18 female, ages were 31 to 52. During this period, a total of 4,046 cataracts, so you can get an idea of the incidence of the cataract. All the patients were implanted with hydrophobic IOLs, 6 had a PCR, 13%, and no patient with a bilateral polar had a PCR in both eyes. What was surprising was all patients who had a PCR were greater than 40 years of age and had an associated NS or a larger posterior plaque. So this is the patients where you need to be careful. 41 patients had a visual acuity of 612 or better, and 84% had 6.9 or better. Now this is a comparison of the various studies. So our PCR rate, if you come to the second last column, is 13%, which is in the acceptable range. So conclude, it's a known surgical challenge. PCR rate was 13%. Basic tenets are pre-op counseling, low for parameters, do only delineation, no rotation, and you can generally have very good outcomes in these patients. Thank you.
Like, did any one of your patient had Daljit Singh sign, which you have mentioned? Like, any one of your patient had Daljit Singh sign, which you have mentioned? No.
Okay. My presentation today is about hypermature cataract. Hypermature and mature intumescent cataract. All phacosurgeons have a problem with such cataracts, irrespective of your experience, because these are the things which happen suddenly. Okay. So, mature and hypermature cataracts pose many difficulties during surgery, and some of them, tearing of the capsule is one major such complication. Other issues like zonular weakness, calcification of capsule, very hard nucleus, other factors which cause GVP are some more. Now, what are the salient features? The main problem is an increased intralenticular pressure, and the capsule is very fragile. Usually there are systemic associations, general neglect, and the nucleus is hard and may have retinal afflictions also. This is how it looks, like a bag of milky white substance. And we all know about this sign known as Argentinian flag sign. We all know Lionel Messi for football, and that's what Argentina's flag looks like, but we know it for some other reason. Then why exactly does it happen? because the white cataracts and intumescent cataracts have an increased pressure created by the hyperhydration of lens fibers, which can cause spontaneous tears in the capsule on poking for a capsulorhexis. Before I go into my technique, I would like to say a word about bandage. What is a bandage? We all know bandages. It causes immobilization, reduces further damage, prevents wound from spreading, and stability. We have the viscoelastic substances, which are cohesive and dispersive. Cohesive, as we know, it maintains the space, and dispersive for endothelial protection. The mechanism is that the cohesive viscoelastics adhere well to themselves and through intramolecular interactions, therefore resist the cleavage, and they have high pseudoplasticity. So there are two steps to this technique. First is cohesive viscoelastic acts as a bandage, flattening the anterior capsule. And the second is when you puncture and whitish milky fluid is coming, you quickly aspirate it with a 26 gauge hydrodissection cannula. Thus, I'll show the animation at the end. The advantages are it is extremely simple, no excessive instrumentation is required, easy to learn, inexpensive, and a high success rate. Argentinian flag sign completely can be avoided by this technique, and doing hypermature cataract is no longer difficult. So dual technique helps us be great surgeons, and let us remember Argentina for Football Gold Cup rather than Argentina flag sign. Now I'll show you a video. It's an animation. Yeah, it's a very short animation. Self-explanatory. We're putting the cohesive viscoelastic, which flattens the anterior capsule. Capsulotomy. Aspiration of the liquefied cortical matter. Phacoemulsification, followed by placing the IOL and washing away the visco. So it can be largely simplified by doing this technique, and the success rate is very, very high. Even in inexperienced hands also, the cohesive viscoelastic acts as a bandage. Thank you.
Thank you, ma'am. How is your experience regarding with an air bubble?
Ma'am, despite the air bubble, what happens is air bubble is not that strong to avoid this kind of, sudden rupture. If you see, it happens so suddenly that the air bubble also, it's a good thing. There are lots of other techniques, like you use a phaco itself to do a puncture. Then you can do, in bits and pieces, like in circles, you can go and do the capsulorhexis, which requires a very high level of skill, firstly. And secondly, this technique, if you put a good viscoelastic, that is a cohesive viscoelastic, and then carry on, you have enough time to suck out the liquefied cortical matter, and then the regular way you can do the rest of the surgery. So that's why I in my hands, I've done 69 such cases, though I have not done the statistical analysis. Not even a single case I faced after I discovered this kind of a technique. I have not faced any problem with any kind of cataract. That's why. Thank you.
Okay, thank you.
Good afternoon to all the faculties and the delegates present over here. Today I'll be presenting a study on IOP elevation after cataract surgery, a comparative study between the residents and attending surgeons. Cataract surgery is one of the most commonly performed surgical procedures worldwide. Elevated intraocular pressure has been a frequent adverse effect, with incidence being 2.3 to 8.9%. The elevated IOP is most commonly it resolves on its own, but in certain cases it can lead to significant visual loss. This study aims to directly compare the rate of IOP elevation post-operatively day 1 after resident performed surgeries to the surgery performed by attending surgeons, and to examine other variables associated with the development of transient elevation of IOP. A retrospective study on 1,370 eyes was done in a tertiary center. Manual small incision cataract surgery was performed by the resident trainee and the attending surgeon. Preoperatively, perioperatively, and postoperative data were collected. Pre-op data included the patient age, sex, history of diabetes mellitus, and other systemic conditions, and IOP using calibrated Goldman applanation tonometer. And perioperative data included any vitreous loss or surgical complications. Post-operative IOP on day 1 was recorded. Any patients who had gone at least one cataract surgery with pre and post-operative data were included in the study, and patients with combined cataract surgery, pediatric cataract cases, traumatic cataract, known glaucoma were excluded from the study. Manual small incision cataract surgery was performed under peribulbar anesthesia. A dispersive viscoelastic agent was used to fill the anterior chamber. In all the uncomplicated cases, after the lens removal, the capsular bag was filled with viscoelastic, and the viscoelastic was removed through coaxial irrigation and aspiration. Our study, the result was on post-operative day 1, the incidence of IOP elevation was significantly higher in resident surgeon group as compared to the attending surgeon. Vitreous loss, resident surgeon, pre-existing glaucoma were the significant risk factors. This is the demographic details of the patient. As you can see, the IOP was risen in almost all the cases done by the resident trainee. These are the risk factors for the rise in IOP, which is maximum in vitreous loss, high axial length, and glaucomatous eyes. Transient IOP elevation in the early post-operative has been described after cataract surgery. Post-operative inflammation, release of vasoactive agents, blockage of the trabecular meshwork are one of the reasons for cause rise in IOP. This study concluded that glaucomatous and myopic eyes are one of the significant risk factors for high IOP. Surgical trauma, watertight wound closure, retained lenticular debris, release of the iris pigments, retained viscoelastics. The residents tend to not aggressively wash the viscoelastic material, so they tend to cause a rise in IOP. Prolonged surgery time in the resident trainee cases is also one of the reasons for rise in IOP. Now, the study concludes that the understanding the variables that may be associated with an increased likelihood of an elevated post-op IOP will help in preventing and treating this transient but potentially harmful complication. Thank you.
It was not clear how many did the residents perform and how many did the seniors she had it?
Total cases were 1,370, out of which 1,096 cases were done by the attending surgeons and 274 cases were done by the resident trainees.
So you compared?
Yes, ma'am. Yes, ma'am. We compared it, but in all the most of the risk factor cases were done by the attending surgeons also only. But still, in all the cases, the IOP was more and significantly more in the cases done by the resident trainees.
Also, you have not mentioned which year residents they were, whether they were second year, whether they third year. So resident trainee, as in the first year, obviously they are the newcomers.
No. Sir, in our institute, like third year trainees does the cataract surgery. Yes, sir.
One thing you said that glaucomatous and myopic, so those were done by the attending surgeon or by the residents?
Ma'am, both, but major cases were done by the attending surgeons.
Okay,
Thank you, ma'am.
Good afternoon, everyone. So today I will be discussing about management and outcomes of manual small incision cataract surgery in cataract with corneal opacity. The authors have no financial interest to disclose. Cataract is the leading cause of blindness in India, followed by corneal opacity. The opacity will limit the surgical field by hampering the visualization of intraocular structures, thus posing various challenges like increased risk of incomplete capsulorhexis, retained risk of cortex, and posterior capsular rent. The advantages of MSICS over phaco include easier to perform procedures like sphincterotomy, optical iridectomy, managing without a complete capsulorhexis, apart from being affordable and cost-effective. So the aim of this study was to evaluate intraoperative management of cataract with corneal opacity and to report the outcomes of the surgery done in patients with corneal opacity. So we did a retrospective study and included 286 patients having cataract with a pre-existing corneal opacity who underwent MSICS during a study period of 2 years. The pre-operative findings were noted, corneal opacity findings were noted, and the corneal opacity was classified according to the Agrawal classification into nebular, macular, leukomatous, and adherent leukomatous opacity. We did a pre-operative A scan using IOL Master 700. In patients with dense media opacities, immersion biometry was used. In patients where the keratometry reading could not be obtained due to irregular corneal Meyers, other eye keratometry reading was used. When both eye keratometry reading was not obtained, an arbitrary K reading of 44 and 45 diopter was used. MSICS was done under subtenous anesthesia. Intraoperative complications, BCVA, anterior and posterior segment examination was noted on day 1 and day 30. We had done certain procedural changes for these patients, like making the corneoscleral tunnel on the steeper meridian for all patients. For pupillary dilatation, we had used intracameral adrenaline, multiple sphincterotomy, stretch pupilloplasty, and iris hooks were used. Optical iridectomy was done in some patients. The anterior capsule was stained with tryphan blue dye, and rhexis was done under retroillumination. Coming to the results, the most common type of corneal opacity was nebular opacity, the etiology being trauma and followed by viral and fungal keratitis. Most of the opacities were either centrally or paracentrally located. For the intraoperative management, 33 patients underwent multiple sphincterotomy. Capsular tension ring was used in 4 patients. Optical iridectomy, iris hooks, and stretch pupilloplasty was done in some patients. Coming to the intraoperative complications, the rate was 4.89%, amongst which PCR was seen in 7 patients, zonular dialysis was seen in 2 patients. 2 patients had whole bag removal who were managed consecutively by placing a scleral fixated IOL. Iridodialysis and Descemet membrane detachment was also seen. The day 1 post-op complications were like iritis, corneal edema, blood clot in anterior chamber, and they were managed medically. There were 3 patients having retained cortex in the anterior chamber, and the post-op complications on day 30 included minimal residual cortex and 6 patients having mild descent at IOL. So the mean logMAR BCVA improved from 1.08 preoperatively to 0.30 postoperatively at 1 month. 88.5% of our patients were having a BCVA more than 618 at 1 month follow-up visit. So cataract with corneal opacity reduces the intraoperative view during surgery, leading to higher chances of complications. But owing to the lesser availability of good quality of donor corneas, the risk of graft rejection, and the need for meticulous postoperative follow-up, it is often difficult to carry out a triple procedure in many patients of the developing countries. So MSICS can be done in these patients. To conclude, MSICS is a safe and feasible therapeutic procedure in providing ambulatory vision in cataract patients having pre-existing corneal opacity. These are my references. Thank you. Ma'am, actually, because of the corneal opacity, we had done the sphincterotomy only in the area where we needed a better visualization. So, and some patients were having small pupil. And apart from that, for the corneal opacity itself was covering a larger area. So we had to do sphincterotomy in order to have a good visualization, especially for rhexis and the cortex removal.
Pupillary dilatation, it was not adequate in those patients?
In some patients, yes, ma'am. A major reason was because of the corneal opacity, ma'am.
So majority of your cases had central corneal opacity?
Yes, ma'am. Either central or paracentral opacities, ma'am.
Dr. Neelsha, thank you.
Thank you.
Are you there?
Hello, good afternoon, everyone. So I'm going to present case on bilateral congenital lamellar cataract. The prevalence of childhood cataract is 1.2 to 13.6 cases per 10,000 children. It's a treatable, it's a leading cause of childhood blindness. So it accounts for 7.4 to 15.3% of pediatric blindness. Lamellar or zonular cataract is a hereditary cataract. It is transmitted in an autosomal dominant mode. It affects one or more layer of lens irregularly and asymmetrically. Most often, the fetal nucleus, generally the embryonic nucleus, is not affected. In the case, 15-year-old male child from Satgavan came with the complaints of both eye diminution vision since childhood. Antenatal history was uneventful. Birth history and weight, it was uneventful. And developmental milestones achieved as per age. His father was diagnosed to have congenital cataract. On examination, visual acuity distant, it was right eye 5/60 with pinhole not improving. In left eye, it was 6/60 with pinhole not improving. Near vision was N12 in both eye. External examination of child was normal. On slit lamp examination, late conjunctiva scleral corneal examination was normal. Anterior chamber examination was normal in depth and content. Iris was also normal in color and pattern. Pupil round, regular and reacting bilaterally. On lens examination, the image is shown here. Opacity is noted in the central core of nucleus with small linear opacities like spokes of wheel seen towards the equator, suggesting lamellar cataract. IOP was 16 mm of mercury in right eye, left eye 14 mm of Hg. Roblas was negative bilaterally and fundus was within normal limit. So congenital cataract basically unilateral and bilateral. Unilateral cataract causes ocular abnormalities, traumatic, idiopathic, and bilateral cataract is maternal infections like torch, hereditary, genetic, metabolic, and idiopathic. Evaluation of the pediatric cataract include history, special emphasis on family history to rule out hereditary causes, history of child growth, development and systemic disorder, followed by genetic evaluation. Physical examination, in examination part, physical examination followed by visual function, corneal diameter, any abnormality in the iris, anterior chamber depth, cataract morphology, posterior segment evaluation, and in ocular imaging, B-scan and ultrasound biomicroscopy was included. In investigation, if the patient is known to have hereditary, then it is we can avoid it, but in undiagnosed case, we should go for CBC, blood sugar, torch titers, VDRL, blood urea nitrogen, red cell galactokinase, serum calcium and phosphorus. Urine analysis was also included. Unilateral cataract does not typically require extensive diagnostic evaluation. Axial length measurement was done by, in this case, ultrasound by microscopy. Keratometry, especially, we have to check the readings. In younger child, it obtained under general anesthesia using handheld keratometer. The IL power calculation, we have to see the child. If we aim at emmetropic child, if we give IOL at emmetropic power, it risks myopia when the child matures, and if we aim for early hyperopia, then it may predispose to child to amblyopia. So under correction, according to the Dahan's and residue formula, like less than 2 years 20% under correction, 2 to 8 years 10% under correction. According to post 1 to 2 years 20%, 2 to 4 years 15% under correction, and 4 to 8 years 10% under correction. So the take-home message for that, the childhood cataract requires early detection and timely treatment. Unique surgical management is different from the adult cataract. Amblyopia aggressive treatment is needed, and lifelong follow-up is mandatory to check for retinal detachment and glaucoma. Thank you.
Thank you. Dr. Bhagavat Nayak, are you there? Dr. Shikha? Rohan? Dr. Rohan? Yeah, please.
Good afternoon, everyone. I'm Dr. Rohan Prasak from Sri Ramchandra Medical College. To begin with, quality of life is an important and often overlooked parameter in glaucoma management. Quality-adjusted vision years is a new concept that targets the maintenance of quality of life. Our aim was to assess the quality of life in glaucoma patients using a novel questionnaire, which consists of 3 different types of scales, namely the generic, the vision-specific, and the glaucoma-specific scales. This was a prospective case control study done at a tertiary care center in Chennai from April to December 2022, recruiting about 30 patients with and 30 without glaucoma. Primary glaucoma diagnosed patients above the age of 40 without any other ocular pathologies were included in this study. This questionnaire focused on generic domains such as health, social functioning, and dependency, as well as glaucoma-specific domains such as central and near vision, peripheral vision, and dark adaptation and glare. This consisted of a total of 25 questions with 5 options for each question assigned a score of 1 to 5. Higher scores indicated difficulty with a certain task, and since 3 questions pertain to driving, which wasn't a common activity for all our participants, an index score was calculated for each question, which was the ratio of the patient score to the maximum possible score for that question, and was compared between the domains and the component questionnaires. So there was no difference noted between the mean ages and genders of both cases and controls. Most of the patients fell into the moderate glaucoma category, whereas patients above the age of 70 mostly fell in the severe category. Statistically significant difference in the mean scores were observed between the cases and controls, except in the mild group. Among all domains, better quality of life with lower scores were noted in the general and mental health domains, whereas dark adaptation and glare had higher scores, indicating poorer quality of life. Mild and moderate cases assigned higher scores to dark adaptation and glare, whereas the severe glaucoma patients had difficulty with peripheral vision. So popular questionnaires like the SF6D and the GQL15 focused on either the generic or the glaucoma-specific domains, but our study amalgamated the strength of both. The AIOC2023 was a good compilation, but lacked a very important aspect, that is the dark adaptation and glare. So glaucoma, being a chronic disease, tends to cause a combination of visual, psychological, and social dysfunction. Similar to previous studies, a consistent pattern of decline in quality of life was noted with increasing visual field loss. Scores of the early glaucoma group and controls were significantly lower than that of the moderate and severe glaucoma groups, in line with what was found with the meta-analysis done by Wang et al. In conclusion, physicians often limit glaucoma management to objective measures and tend to overlook the functional vision and its effect on quality of life. The hybrid questionnaire gives a wholesome assessment of various domains of quality of life and highlights the difficulties faced by glaucoma patients on a daily basis. Along with objective tests, patient-reported outcomes may be employed to raise awareness. This study had certain limitations. It mainly used objective measures which were easily influenced by age, sex, cultural beliefs, etc. There was no consideration of education level and occupation, and there was a significant deficit of psychophysical and performance-based tests like the Pelly-Robertson contrast sensitivity charts. This was a data collected from a tertiary care hospital and may not be representative of the entire population as a whole. Thank you.
Thank you. New perspective on glaucoma. And another limitation I've found at the financial background also, economic, the cost of glaucoma drugs, anti-glaucoma drugs, that could also be a part which could add in it.
We'll include that, ma'am. Thank you.
Thank you.
So very good afternoon, everyone. I'm presenting a rare case of Bardet-Biedl syndrome. So he was a 17-year-old male who was under regular follow-up for progressive diminution of vision due to high myopia and amblyopia with posterior staphyloma since past 2 years. His refractive error was best corrected visual acuity of 1 meter finger counting with -7 to -2 cylinder for right eye and 636 in left eye, -6 with -3 cylinder at 160 degree. Now he was admitted few months back to a multi-speciality hospital with signs of acute renal failure. So this was his ophthalmic examination. The uncorrected visual acuity was a near finger counting in near right eye, 1 MFC in left eye, and the intraocular pressures were normal, anterior segment was normal, The posterior segment showed posterior staphyloma, extensive myopic macular degeneration, and a diffuse disc pallor in both the eyes. So this is the fundus picture showing extensive myopic macular degeneration and disc pallor. This is the OCT findings showing the posterior staphyloma with macular thinning. So coming to the systemic findings, he had recently developed the acute renal failure, and he had almost all the features of the Forsyth and Beale's clinical diagnosis. Besides the cone and rod dystrophy, he had truncal obesity, there was mental retardation, there was hypogonadism with decreased testosterone levels of 55 nanogram per deciliter, there was chronic kidney disease. It was a renal parenchymal disease as diagnosed on renal biopsy. So he had all the major symptoms, major features. Only thing that was missing was polydactyly. The minor features included the secondary hyperparathyroidism with parathyroid hyperplasia, dysmorphic craniofacial features like down-slanted palpable fissure, deep and widely set eyes, depressed nasal bridge, and there was a nasal speech. There was history of consanguinity. So his clinical exome analysis was done at Medigenome Narayana Nethralaya, which revealed Bardet-Biedl syndrome 16 SDCCA8. Location was autosomal recessive, exon 12. So this was the finding on genome analysis. So what was important here was, besides the routine features, although polydactyly is considered to be a primary feature of BBS, overall it has not been reported in any of the BBS 16 cases. So this was the picture. The picture was taken after the consent from the patient, having all the features described. So as discussed, all in one: cognitive impairment, dysmorphic craniofacial features, speech abnormalities, poor vision with retinal degeneration, hyperparathyroidism, obesity, CKD, and hypogonadism. So coming to the treatment, individuals with BBS required coordinated multidisciplinary care to formulate and coordinate management and therapeutic interventions. So low vision aids were suggested, counseling of the parents were done regarding the future of the child. Future need of retinal replacement therapy, as he was already in CKD, so he might be needing a dialysis or a renal transplant, or maybe somewhere in future if we have artificial kidneys. The neuropsychiatric development program for MR was suggested, vocational training was suggested, and he was started on endocrinological treatment for hypogonadism, for which he was given testosterone injections, and a treatment of hyperparathyroidism was started. So thank you so much.
Was any electrophysiological test done?
No, sir. Actually, it was not available, and initially the patient was even not ready for the exome analysis. It was only once he developed that acute renal failure that he understood the importance. So it was not done. And visual field, since the patient had a poor vision, we did not do. Yeah. Thank you.
Chaudhary.
A very good afternoon to one and all present here. I'll be presenting toxic nutritional optic neuropathy among females belonging to Dimasa tribe of Northeast India. I have no financial disclosures. Of the many wonderful, colorful tribes of Assam, Dimasa tribe people belong mostly to the Dima Hasao region, and the Mar tribes belong to in and around Mizoram region of the state. I hail from Kachar, so I get a lot of indigenous people coming mostly from Dima Hasao and in and around from Mizoram. So toxic nutritional optic neuropathy, as we know, can cause severe visual loss. However, timely management gives favorable results. The purpose of this study was to report toxic nutritional optic neuropathy in 7 young and healthy women belonging to these indigenous communities. All patients presented with diminution of vision. A detailed history was taken, and all patients gave history of tobacco use in liquid form, while 2 patients gave history of occasional smoking. So what is this liquid tobacco? I had seen a couple of my patients taking sips from this bottle, from their bottle in their hands, this brown colored liquid, and I was really intrigued. So the local name is Tuibur or Hidakfu. It's a form of tobacco water which is mainly popular in northeast states of India, and it's a part of social customs, and it has got widespread cultural and social acceptance. It's almost as common as tea or coffee. And there is also a misconception that water causes purification of the tobacco, so it's extremely safe. I was even more interested now, so I actually went to a local Mar village. First, the tobacco is dried up, then they put it on fire in an earthen pot, and the smoke is then using a hand pump directed into the water. And this is done manually, and once the water becomes super saturated with the smoke, tobacco smoke, cloth filtration is done, and this is the final result. The people were very generous, very welcoming. They also offered me a drink, and I had to respectfully decline. So this is the mechanism. Hydrocyanic acid and free radicals in the tobacco, they cause damage to the mitochondrial respiratory chain of DNA. Modifications happen in mitochondrial morphology. This leads to demyelination. So all patients underwent clinical evaluation along with visual fields, OCT, and they were put on oral vitamin B complex supplementation for a period of 3 months. They were advised to discontinue this Tuibur use. This is one typical patient, had a fairly normal fundus, very minimal temporal RNFL thinning on OCT. They had a dense central scotoma, which improved dramatically after 1 month of vitamin B12 treatment, and they got a vision of almost 6/9. This is a few more patients. So vitamin B complex supplementation has been successful in treating patients with tobacco amblyopia. The protective effect is believed to be due to conversion of free cyanide into cyanocobalamin. So all 7 patients had a dramatic visual improvement after using vitamin B12 supplementation. There was improvement in the visual acuity and field indices as well. Although it has been documented, tobacco use in a liquid form has been documented, but to our knowledge from PubMed, Google Scholar, Science Direct, this is the first study linking Tuibur or tobacco water use to toxic nutritional optic neuropathy. So to conclude, toxic optic neuropathy can be caused by a multitude of agents, and the mainstay of treatment is replacing the deficient nutrients and eliminating the offending toxin. It is also very important to consider contributory social, cultural, and dietary practices. Thank you very much.
Thank you so much. Very socially relevant and new perspective. We were not aware of this, and I think you should get it published.
Thank you.
So, thank you so much.
Just one thing I want to ask, like, have you done the nutritional assessment of this?
Yes, I have, and most of the patients actually had normal vitamin B12 levels. Thank you.
Dr. Mayuri?
Good afternoon, everybody. Today's my topic is case report on nanophthalmus with associated retinitis pigmentosa. Coming to introduction, nanophthalmus is a rare genetic disease with small eye secondary to the compromised growth and is characterized by shortened axial length, generally less than 20 millimeters, at least 2 standard deviation below the age-matched controls. High lens by eye volume ratio with narrow iridocorneal angle, high hyperopia ranging from +8 to +25 diopter and scleral thickening. It is associated with angle closure glaucoma, axial hypermetropia, amblyopia, corneal steepening, irregular astigmatism, optic disc drusen, retinitis pigmentosa. Coming to first case, she was a 41-year-old female presented to us with complaints of redness and pain both eyes occasionally from the past 1 year. On questioning, she has given the history of night blindness from the age of 20 years. She has never used glasses since childhood. On examination, her vision was 22/60 right eye and hand movements in left eye with refractive error of +14 diopter spherical in right eye and +13 in left eye. Slit lamp examination showed right eye showed clear cornea with shallow anterior chamber, sluggishly reacting pupil with early lenticular changes, and left eye showed edematous cornea, shallow anterior chamber, mid dilated and non-reacting pupil with early lenticular changes. IOP was 12 in right eye and 68 millimeters of mercury in left eye. Gonioscopy showed closed angles both eyes. YAG peripheral iridotomy was done in both eyes after controlling IOP. 1 week follow-up visit showed vision was 2/16 right eye and 3/16 left eye with patent peripheral iridotomy both eyes. IOP was 14 millimeters in right eye and 20 millimeters in millimeters of mercury in left eye with topical and systemic AGMs. Fundus showed pale disc with arteriolar attenuation and pigmentary degeneration of the retina in both the eyes, and macula was normal with dull FR. Axial length was 15.45 millimeters in right eye and 15.71 millimeters in left eye. The patient had both eyes nanophthalmos with chronic angle closure with high hypermetropia, amblyopia and retinitis pigmentosa. This is the fundus photo showing both eyes pale disc with arteriolar narrowing and pigmentary changes in the periphery. Second case was a 35-year-old female complaining of diminution of vision and abnormal eye movements both eyes since childhood. On examination, she had nystagmus esotropia, PL positive with clear cornea and pseudophakia both eyes. IOP was 16 in both eyes with open angles. Axial length was 19.12 millimeters in right eye and 20.45 millimeters in left eye. Fundus showed pale disc, attenuation of arteries with pigmentary degeneration of retina suggestive of retinitis pigmentosa both eyes with consecutive optic atrophy and right eye nanophthalmos. Coming to discussion, nanophthalmos is a rare clinical spectrum of disorders with phenotypically small but morphologically normal eyes. Small development of retina, retinitis pigmentosa and other retinal anomalies have also been reported in nanophthalmos. It can be shown in two theories. The first one is in already underdeveloped eye of nanophthalmos, lack of full development of the retina in the later part of the fetal life is responsible for pigmentary retinal dystrophic changes. And the second theory was possibility of the presence of prior uveal effusion causing secondary retinitis pigmentosa after retinal detachment. Uveal effusion and non-rhegmatogenous retinal detachment may occur spontaneously or as a complication of ocular surgery in nanophthalmos due to impaired venous drainage because of thickened sclera. Coming to conclusion, nanophthalmos can be unilateral, though it is most commonly bilateral, and the cause for visual decline in nanophthalmos is not only the higher hyperopia, thereby amblyopia, glaucoma, uveal effusion, but also pigmentary retinal degenerations like retinitis pigmentosa. These are my references. Thank you.
Was there any OCT done in these cases?
No, sir. OCT was not done, sir. Just fundus examination was done by a retina consultant.
Because OCT in a nanophthalmos shows crowded retina at the fovea. There is loss of foveal count.
Yes, foveal thinning might be there.
The OCT in these
Yes, sir. Next time I will do, sir. When the patient comes for follow-up, I will definitely look into it. Thank you, sir.
Good afternoon, everyone. And today I shall be presenting an interesting case of hemorrhagic fever which presented with bilateral eyelid ecchymosis and subconjunctival hemorrhage. A 17-year-old boy presented to us in the emergency department with complaints of redness in both eyes and vomiting. There was no history of trauma or any fall of foreign body in any of the eyes. Ocular examination showed bilateral eyelid ecchymosis in an arcuate fashion with subconjunctival hemorrhage, as you can see in the figure, and this was not associated with any kind of discharge. Visual acuity was 6/6 in both the eyes. Pupillary reactions, IOP and fundi were normal. A provisional diagnosis of idiopathic ocular hemorrhage was made, and the patient was treated conservatively with cold packs and topical naproxen eye drops. He was advised to come to the IOPD for review after 1 week. Analysis of the systemic presentation showed interesting sequence of events, as when the eye was examined on day 1, the general condition of the boy was fair with maintained vitals, and he was given supportive treatment of antiemetics, and a complete blood count was ordered by the physician. He was kept under observation in the emergency department for 24 hours. The next day he developed fever, became drowsy and disoriented with a pulse rate of 100 per minute and blood pressure of 90 by 56 millimeter of mercury. He was transferred to intensive care and given noradrenaline, antipyretics and volume replacement. CVC by the time was available, and it showed that he had a reduced platelet count of 11,000, suggestive of dengue hemorrhagic fever. Then he was transfused 1 unit of platelet concentrate. On day 3, he developed abdominal pain and had blood in his stools. A further unit of platelet concentrate and 1 unit of packed cells were transfused. Ultrasound showed gallbladder edema, a enlarged hypoic liver, and a free fluid in abdomen. By this time, the dengue serology was positive. On treatment, the patient's condition improved, but his ocular findings persisted for a week. As we all know, classically dengue presents with fever, headache, retroorbital pain, nausea, vomiting, joint pains, and effects of thrombocytopenia. And the usual sequence of events is acute febrile stage of 2 to 7 days, which may or may not be followed by recovery. During defervescence, some develop dengue hemorrhagic fever, which may progress to dengue shock syndrome. And the risk factors for development of dengue hemorrhagic fever range from viral factors to individual factors and epidemiological factors. Dengue has wide spectrum of ocular manifestation, most common being blurring of vision, and the reason being dengue-related maculopathy. A central scotoma also is known, corresponding to the areas of edema and hemorrhage on the macula. Then subconjunctival hemorrhage is also quite common. Uveitis, optic neuropathy, and vitreous hemorrhage are very less common, and eyelid ecchymosis is extremely rare. Ophthalmic manifestations are rare as a presenting feature. Bilateral eyelid ecchymosis has not yet been described as a presenting feature of dengue. The present case is incongruous in the way that the systemic involvement at the type of presentation was not proportionate to the ocular findings. Further, eyelid and subconjunctival hemorrhages were present without any retinal hemorrhages. To conclude, bilateral eyelid ecchymosis as a presenting feature of dengue fever is rare and has not been previously reported. Trivial signs such as ecchymosis and subconjunctival hemorrhages are to be viewed with caution. And if these signs are present, then the patient should be investigated for systemic causes. Lastly, physicians also need to be made aware of such a clinical presentation to avoid wrong diagnosis. Thank you.
Thank you so much. Yes. You have come, Dr. Shubhangi. Yeah, please come.
Thank you, All India Ophthalmic Society, for giving me this opportunity. It is a case report of herpes zoster ophthalmicus. Okay, so first patient, a 63-year-old lady, she presented my routine ophthalmic OPD with maculopapular rash on the left side of forehead and upper eyelid region with swelling in cheek with acute anterior uveitis. This was the second 46-year-old lady. She presented with vesicular lesions on right side of forehead and upper lid with lid edema and conjunctival congestion with chemosis. And this is the third elderly lady, 60-year-old. She presented with extensive developed crusted lesions on right side of forehead. They were there since last 10 to 12 days with severe pain, and she had associated complete third nerve palsy. So coming to varicella zoster virus, it is a neurotropic human herpes virus of genus Alpha herpes viridi. The infection occurs in childhood and it spreads by airborne droplet and contact transmission. It results from reactivation of the latent varicella zoster virus within a sensory nerve ganglion, presenting decades later after the initial infection. The disease typically presents as a unilateral maculopapular or vesicular rash in a single dermatomal distribution. There are 3 stages. First, pre-eruptive stage, there is a burning or pain within affected dermatome at least 2 days prior to cutaneous eruptions, and associated symptoms can be headache, general malaise, photophobia. In acute eruptive phase, there are multiple umbilicated painful vesicles. Then they burst, ulcerate, and eventually dry out. This is the most contagious stage, and pain can be severe and unresponsive. Chronic stage, if there is severe pain that lasts more than 4 weeks, there is dysesthesia, paresthesia, and shock-like sensation can also be there. PCR is useful for confirmation of suspected herpes zoster type pain if there is no associated rash. Coming to ophthalmicus, it is involvement of the ophthalmic division of the trigeminal nerve. 50 to 85% of the cases they have associated ocular complaints, and rare manifestations can be sterile iris abscess, third nerve palsy, orbital fissure syndrome, apex syndrome. It is an ophthalmic emergency due to the risk of vision loss if it is not identified early and treated well. Main risk factors for ophthalmicus are age more than 50 years and associated immunosuppression. So possible complications can be orbital cellulitis with a risk of secondary blindness, acute retinal necrosis, uveitis, epithelial keratitis, corneal inflammation, and if not treated, opacification. And patients with herpes zoster ophthalmicus, they have 1.3 to 4% increased risk of cerebrovascular events. So the treatment part, it can be supportive line of management. And coming to antiviral, systemic antiviral, in immunocompetent, we can try, we should give acyclovir 800 milligram orally 5 times per day for 7 days, or valciclovir. Then in immunocompromised, the dosing is 10 milligram per kg of idle body weight every 8 hours for 7 days. And in acyclovir resistant or severe form of cases in immunocompromised, we can give foscarnet. Then again, there is a role of antibiotics to prevent secondary infections, steroids, and topical aqueous suppressants if there is raised IOP. So coming to COVID-19 vaccination can increase the risk of varicella zoster activation. And these all available vaccines, they have been found to potentially reactivate varicella zoster virus. Coming to varicella herpes zoster vaccines, there are 2 vaccines, a live attenuated Zostavax, and second is a recombinant glycoprotein E subunit vaccine, which is Shingrix. And prevention and treatment, something about post-herpetic neuralgia. So while non-steroidals, they are not effective in post-herpetic neuralgia, we can try for tricyclic antidepressants, selective serotonin reuptake inhibitors, gabapentin, pregabalin. Then there are even newer methods are there for the management of post-herpetic neuralgia. Thank you.
Thank you. Any corneal involvement did you see in those cases?
No, in these 3 cases, I could not see
Hutchinson signs. And seropositivity? HIV? Yeah.
If you see a new eruption, then you can give, but ideally it should be given within 72 hours. Then only it will be effective.
Dr. Anisha? She's going to take a look at an eye bombarded with effects of systemic lupus erythematosus.
Good afternoon all, myself Dr. Anisha, taking you to look at an eye bombarded with effects of systemic lupus erythematosus. So there is this patient, 24 years old female, who is a known case of SLE and lupus nephritis on treatment with hydroxychloroquine and mycophenolate mofetil, presented with left eye redness, foreign body sensation and photophobia. So on clinical examination, her best corrected visual acuity was 6/6, 6/9 in right eye and left eye respectively. Intraocular pressures were normal, and her right eye anterior and posterior segments were normal. Coming to left eye, so in the nasal periphery, we were able to see some sterile infiltrate, stromal thinning, vascularization, but the anterior chamber was quiet and the fundus was normal. So we came to a conclusion it's a peripheral ulcerative keratitis, and we started her on topical steroids, and at the same time her systemic immunosuppressants were continued and she responded well to the treatment. But later again, she developed blepharokeratoconjunctivitis secondary to meibomitis and meibomian gland dysfunction, which again responded well to the systemic and local immunosuppressants and bilate hygiene measures. And then she developed an episode of severe ulcerative blepharitis with severe meibomitis in both eyes. So since this is recurring, we sent her eyelash samples for microscopy, and it came out to be Demodex, for which we gave her tea tree oil scrubs, and at the same time her immunosuppressants were continued. Then later again, she developed right-sided facial paralysis secondary to herpes zoster, with lag of thalamus. Post this, she developed right eye exposure and neurotrophic keratitis with secondary microbial infection, which was treated with topical antibiotics. And later we had to do her right eye lateral paramedian tarsography, and presently right eye lag of thalamus is resolved and both eyes corneal surface is stable. Currently she is on lubricant eye drops and general ocular hygiene measures. So coming to systemic lupus erythematosus, it is a chronic autoimmune connective tissue disorder of multiple organ systems, including joints, skin, kidneys, and brain. It typically has a relapsing and remitting clinical course. The eye is frequently involved in SLE, and the disease may cause ocular involvement by several mechanisms, which includes immune complex deposition in the basement membrane of small blood vessel endothelial cells. And ocular complications have been reported in up to 1/3 of patients with SLE. Keratoconjunctivitis sicca is the most common ocular manifestation, and corneal involvement has a wide spectrum range of severity, which may present as a very mild superficial punctate keratitis or ulcerative keratitis. So, literature has shown that the patients with systemic lupus erythematosus are on high risk with Demodex infestation, and globally herpes zoster has been reported as the most frequent viral infection in SLE patients. So this is a potentially life-threatening multi-system disease that is commonly associated with ocular manifestations. So because of the systemic nature of the disease involving multiple organs, collaboration among the involved specialists, including ophthalmologists, rheumatologists, nephrologists, and dermatologists, is often required for tailored therapy for each patient, and a better understanding of SLE pathophysiology will facilitate development of more effective treatment options. These are my references. Thank you.
Thank you.